It typically begins with a fever. Next, a distinctive rash starting on the face and spreading across the body. Lots of little blisters filled with fluid. On top of that can come severe headaches, muscle aches, and fatigue. Mpox is a serious and at times fatal virus, and a current epidemic in the Eastern Democratic Republic of Congo, the DRC, is spreading quickly, particularly among young children under the age of 5.
Health workers at the Kavumu hospital say they have admitted 900 people with Mpox in the last...
Africa's top public health agency has declared an Mpox emergency.
The potential for further spread within Africa and beyond is very worrying.
The world knows how to stop Mpox. There are vaccines stockpiled in many Western countries. But after an earlier global epidemic in 2022 was largely brought under control, the ongoing battle to protect people in Africa from Mpox was ignored. In this episode, we talked to a virologist and a paediatrician about Mpox and how it's affecting children. We ask why Africa's Mpox crisis has been so neglected and what needs to happen now to save lives. I'm Gemma Ware, and this is The Conversation Weekly, the world explained by experts. I'm joined to start this episode by Nadine Dreyer, health and medicine editor at The Conversation Africa, based in Johannesburg. Hi, Nadine. Great to have you on the show.
Thank you.
Nadine, in mid-August, the World Health Organization labelled the epidemic of Mpox in the Democratic Republic of Congo, the DRC, a public health emergency of international concern. What does that actually mean?
So it means this is the WHO's highest alert level. It's designed to mobilize vaccines and diagnostic tests and essential equipment to countries in Africa that need them and that can't afford them. For example, in the Democratic Republic of Congo, which is the epicenter of the epidemic, up until recently, there were only 2 labs in the country that could diagnose Mpox. Remember, this is a country of 100 million people. These emergency measures are designed to prevent a pandemic.
And this is the second time in just a few years that an Mpox epidemic has been declared a public health emergency of international concern by the WHO. Where are we with that earlier epidemic?
As you say, the WHO declared Mpox a public health emergency of international concern in 2022 after cases spread to 116 countries, and the WHO declared it over in May 2023. But people in Africa have a bit of a problem with that because in Africa, especially in the DRC, Mpox was diagnosed for the first time in 1970. And since then, it's been endemic on the continent, both in Central Africa and West Africa. So there's a feeling that Mpox has been going on for decades and that in declaring the health emergency over, the WHO ignored Africa and what's going on here. And that could be one of the reasons why we're struggling with the current epidemic.
So it's now early September. What's the latest information we have about the current state of the outbreak in the DRC?
The number of cases reported so far this year have exceeded last year's total, with more than 18,000 cases and more than 615 deaths. Countries like Burundi, Kenya, Rwanda and Uganda are some of the countries that have reported their first Mpox cases. But it's very likely that Mpox cases are grossly underreported, as only 18% of suspected cases have been diagnosed in the DRC. Another alarming development is that children under 5 account for almost 40% of the cases.
So it's a really serious situation for the country with limited health resources.
Yes.
And Nadine, you've been working with a number of researchers to shed some light on the epidemic and what we know and what we don't know about Mpox. We're speaking to 2 of these researchers in today's episode, and I'd like you to introduce them both for us. First of all, tell us about Nadia Sam Agudu.
Nadia Sam Agudu is a world-renowned paediatrician and researcher specializing in infectious diseases. I came across her because she wrote a blog post, Mpox declares to Africa that global health is in fact not global. She has affiliations with several institutions, including the University of Minnesota Medical School, where she's a professor of pediatrics in infectious diseases. She's also affiliated to the Institute of Human Virology in Nigeria and the University of Cape Coast in Ghana.
We'll be hearing from Nadia a bit later in the episode, but the first person we'll hear from is Wolfgang Preiser. Tell us about Wolfgang.
So Professor Preiser is another internationally respected scientist. He's the head of virology at Stellenbosch University in Cape Town and also head of virology for the National Health Laboratory Service, overseeing the Tygerberg district in South Africa. He has researched HIV, COVID, and other viral infections for decades. I reached out to him to collaborate on the story after I read an article he co-authored in The Lancet, calling for decisive action to control the spread of Mpox in Africa.
Great. Thanks, Nadine, for setting out that context and for introducing us to Wolfgang.
Thanks for having me, Gemma.
When I spoke to Wolfgang Preiser in early September, he told me he was glad both the WHO and the African Centre for Disease Control had recognised the severity of the ongoing Mpox outbreak in the DRC.
Why I'm very glad about that is that we are seeing this going out of control. So case numbers are increasing seemingly rapidly, and we are seeing cases in neighboring countries linked through travel to the areas most affected, but it's then only a question of time before then localized outbreaks also start in these countries, and of course then it'll spread further. So this is a virus which we thought was circulating naturally in small mammals in rainforest areas of Africa, but it's just another very worrying reminder that these viruses are good for nasty surprises.
In May, Wolfgang had joined a call to action by the Congolese-American doctor Jean Nchega, warning that the Mpox epidemic in the DRC could spread if it wasn't addressed. Sadly, their concerns were validated as the situation worsened. In a compelling article for The Conversation, Wolfgang argued that Mpox is yet another example of how infectious diseases, often perceived as someone else's problem in poorer countries, can suddenly pose unexpected global threats. Mpox was first discovered in 1958 in captive monkeys in Europe and originally labelled monkeypox as a result. The first human case emerged in 1970 in the Democratic Republic of Congo, but the virus was dismissed as a rare infection limited to rural areas in tropical parts of Africa, posing little threat to the rest of the world. That changed in 2003.
The first wake-up call was actually when West African rodents were imported into the United States of America as pets, and they were kept together with the native prairie dogs that were then sold off to the unsuspecting public as pets.
But those small mammals carried the Mpox virus and it infected the prairie dogs.
And they then infected about 70 cases their new owners. It ended mildly in that, these cases were not severe. They had skin lesions and blisters, but it wasn't a huge problem.
The outbreak led to stricter controls of the pet trade in the US, but outbreaks on the African continent continued to be dismissed. Then in 2017, Wolfgang says a small outbreak began in Nigeria.
Colleagues in Nigeria described human-to-human transmission and a significantly increased number of monkeypox cases since 2017. And that was the predecessor that then gave rise to the global outbreak 5 years later.
The rapid spread of a lethal version of Mpox in Africa and now to Europe is causing increasing alarm.
There were suddenly massive numbers of cases in many, many different countries, linked mostly to sexual transmission and mostly affecting men who have sex with men, and some events that lead to a lot of people attending and then traveling back to their areas and countries of origin that really spread. And it just shows how explosive spread can happen.
By May 2022, there were over 99,000 laboratory-confirmed cases in 116 countries. At its peak that August, over 6,000 cases were reported each week. There was a concerted effort to vaccinate the populations most affected by this outbreak in Europe and North America. Then in May 2023, the WHO declared the outbreak was no longer a public health emergency of international concern. But a steady stream of cases continued. But around this time in 2023, a new outbreak had begun in the Democratic Republic of Congo. This was of a different strain of the Mpox virus. Since the first discovery of Mpox in the 1950s, 2 strains of the virus, or clades as scientists call them, have been identified. Clade 1, which used to be called the Congo Basin strain in Central Africa, and Clade 2, the West Africa strain. The 2022 outbreak, which originated in Nigeria, was a variant of the Clade 2, West Africa strain. The current outbreak in the DRC is of Clade 1, and in particular, a new variant called Clade 1b that appears to be better at spreading between humans.
The new Clade 1b strain is primarily affecting the Democratic Republic of Congo with nearly 17,000 cases and over 570 deaths this year alone.
With good healthcare, mortality of Mpox in humans is between 0.1 and 10%, which is very low, especially when compared to smallpox, which can have around a 15 to 45% mortality rate in an unimmunized population. But Mpox is particularly dangerous for children, and in the current epidemic in the DRC, around 40% of those infected are children under the age of 5, and close to 2/3 dying from the disease are also children.
This is actually a manifestation of what Mpox has been in African countries historically.
This is Nadia Sam Agoudou.
I'm a pediatrician with expertise in infectious diseases. The first clinical human case was in an African child, an infant, in DRC in 1970. So we've been with Mpox for over 50 years. And in those first few decades before the 2022 outbreak, children were still a significantly high proportion.
Nadia recently published a study of the Mpox cases that happened in 2022. That was the year of the global outbreak.
When you look at the African region only, children were about 38.5%, that's almost 40%. But even historically, before that, there were reports from African countries where children were up to about 30 or 40%. So what we were seeing in 2022 and even now is not that different from what has been going on historically. It's just that I think more people are getting to learn about that it really is a very pediatric disease.
Why is that?
First of all, the exposures to Mpox are connected to children being at a higher likelihood of having the infection. Now, when Mpox outbreaks started happening in African country, it is a zoonotic disease, meaning that it's connected to animal contact. There are animals who are reservoirs of this virus, and then it jumps into humans and causes disease. Children were having more exposure because you have children, especially males. There's always been a slight preponderance of males. You have more male children sort of going out into the woods, trying to trap animals, whether it's for learning how to hunt or actually trapping animals as part of their contribution to household nutrition. And they would get these infections from having contact with especially large rodents. The disease is now Mpox is because it was first detected in monkeys. They are among the animal reservoirs, but they are not the largest or most important. It's really large rodents. And so some of these large rodents are a source of protein, source of food for many people living in forest or rural areas. And so you'd have more males going to trap these animals and preparing them and getting exposed to them. But now going into the individual sort of biological makeup of children, children are actually born with immune systems that are not ready to fight any or all infections. Their immune systems are still developing. And so for someone like myself who is a pediatrician, pediatricians are really concerned about children under 5 because children under 5 are the highest risk of getting infection and having severe outcomes of infection and death because of their immune system.
Today's outbreak in the DRC is being driven by human-to-human infection rather than zoonotic infection from animals. Children may be infected at school or by adults in their household. The adults may not show any severe symptoms, but when the children catch Mpox, they get it more severely, coming up with lots of skin lesions.
Historically, even before the 2022 outbreak, children were disproportionately represented in mortality. And with what is called the Clade 1, which is more Central Africa, versus Clade 2, which is more West Africa. Clade 1 in itself tends to have higher mortality rates, up to 10 or 11%. And so we are seeing more of that today as well, with children representing high proportions of mortality, especially in DRC, anywhere from 2/3 to 3/4 of deaths being in children.
Even though the high number of cases in the DRC right now is being linked to the clade 1b novel strain of the virus, Nadia says it's actually the original clade 1a strain that's been circulating in Central Africa for decades that's currently affecting children the most. And while some reports are suggesting that clade 1b has a higher mortality, Nadia says that's not yet what the evidence is showing.
1b, the novel strain, is circulating more in men, especially men who have had sexual contact with men, in sex workers, and people who frequent sex workers. In terms of its severity, really the data that we've been looking at recently with the clade 1b, the novel strain, we don't have that much data to tell us that it is more severe than the 1a. In fact, because clade 1a continues to affect children disproportionately, we are actually seeing more deaths in terms of proportion of deaths with clade 1a.
In the way that you look at this as an infectious diseases paediatrician, would you say that there are essentially two epidemics happening at the same time, two outbreaks happening with the clade 1a and the clade 1b?
Absolutely.
Okay. And they're actually separate, they're caused by different factors and dynamics, or are they feeding into each other? How does it all fit together?
Yeah, so I think in terms of the environment, by that I mean areas of conflict where people are internally displaced, where there's violence, where there's insecurity, where they haven't had robust health systems for a long time because of conflict and insecurity, that's feeding into both outbreaks, both the clade 1a and the clade 1b. And that's something that happens with infectious disease over and over again. This time, it's like fill in the blank with whatever infectious disease, especially of pandemic potential. It's going to behave that way. So whether or not you have vaccines, when there's displacement of people, insecurity, fighting, or for example, natural disasters, floods, whatnot, disease starts to brew. And this is the example we are seeing with Mpox right now, even in the setting of two different strains of the same disease.
Unlike the early days of the COVID pandemic, the world's doctors know how to prevent Mpox through vaccination. Mpox is related to smallpox, and so is the history of its vaccine. A smallpox vaccine was first discovered in the late 1800s. After new generations of the vaccine were developed in the 20th century, the WHO organised a mass eradication campaign in the 1960s and 70s, bringing together scientists from around the globe to successfully eliminate smallpox. Here's Wolfgang again.
This was a major achievement, but what it meant is to actually chase that virus from its last strongholds. And they were looking for cases, and if the case was discovered, they went in, they confirmed it, and then there was what we call ring vaccination. So people who had been in contact and then secondary contacts were vaccinated in order to really prevent this smallpox virus from spreading. And at the time already, it was speculated that after a while, you can stop vaccinating. And then, of course, the savings in terms of effort and money, but also in terms of humans having to get that vaccine and maybe suffering side effects. That smallpox vaccine was actually quite poorly tolerated and had some very nasty side effects occasionally.
Since the 1980s, nobody has been routinely vaccinated for smallpox.
I, for one, received the smallpox vaccination when I was in school, but they were, of course, stopped in the 1970s or early 1980s in different countries. And ever since, generations have been born and grown up that have not been vaccinated. The trick being that the vaccination against the smallpox virus would also protect against the other viruses.
It wasn't until the early 2000s that scientists really began to think about pox vaccines again.
That was the time when I became involved with the first SARS outbreak in 2003, but at the same time, it was the start of the second Gulf War. And around the time, there had been the anthrax incidents of posting anthrax containing envelopes to various people in the United States. There had been the alleged bioweapons facilities in Iraq. And there was a concern that smallpox had not been as eradicated as one had thought, officially declared eradicated in 1980, and that there were legitimate bioterrorism or biowarfare preparations around. And in fact, some of the soldiers, or many of the soldiers that then were sent to Iraq, were vaccinated using the bad old or good old smallpox vaccine.
This led to a renewed investment in vaccines and treatments for smallpox and other related pox viruses, including Mpox.
Stockpiles were produced and held, and this is what really benefited humanity. And of course, if I say humanity, in the first line, it benefits those lucky enough to live in the better resource countries. They will have access to this. And both the vaccines and the antiviral treatments were used when in 2022, so just over 2 years ago, monkeypox hit the international scene and spread, caused a massive global outbreak. It was not the original purpose of developing these agents or for stockpiling them, but it just so happened that, they were there when they were needed, which is fantastic and which is something that we now need to leverage to combat the outbreak in Eastern DRC, because we know we have vaccine, we know we have drugs. It remains to be seen how effective either of them are, but at least now is something to start with and to try.
There are 3 vaccines that can be deployed against Mpox infections, and they target both clades. But there are big challenges about getting the vaccines to the countries where they're most needed, and also protecting children. Here's Nadia Sam Agudu again.
The issue is who the vaccines were made for and whether children are eligible for the vaccines. A lot of times when these drugs and vaccines are made, they're typically focused on, first of all, non-pregnant adults, because it's quote unquote easier to do it in these groups and establish. And some of the reasons we give are that to do this among pregnant women or among children, they are thought of as more vulnerable. But a lot of us have argued that this focus on protection for children and pregnant women to an extent is actually harming them, in that we don't prioritize these groups for these drugs and vaccines. And there's a long delay before they can have access. And that's what's happening now. So on account of their vulnerability, they are pushed aside. But then it's because of their vulnerability that they continue to have disproportionate effects and consequences of these diseases.
In early September, the DRC got its first instalment of 100,000 vaccines from the European Union. These were doses of the Bavarian Nordic vaccine, often called Jynneos.
And that vaccine is not to be given in people under 18 years of age. So off the board, you are excluding children.
Another Japanese vaccine called LC16 has been used on children, but it's not gone through all the necessary approvals yet outside Japan.
There are some trials in African countries ongoing for testing these vaccines, their efficacy and safety for children 2 to 12 years of age. They're supposed to be starting these trials maybe in October, and we don't have public data on which countries it will be yet, but I can guess that it would include DRC, right?
Nadia says the lack of vaccine for children means they really need help when they catch the virus.
In the meantime, with the little that we have, we need to make sure that children are well managed. We don't have vaccines. We don't have therapeutics. Isolate these children. Treat the lesions. Children can more easily than adults get blood infection from an infection of a skin lesion. Those lesions, you can see how many people have in terms of severity. Children can be covered in these lesions. Sometimes they itch, they're painful. You scratch on them, dirt, bacteria get in. And then if there's enough of a threshold that is surmounted, we're going to get a bloodstream infection that can threaten the functionality of organs. And that is severe morbidity or death.
For Nadia, this issue about the suitability of vaccines is just one example of the opportunities that have been missed to properly treat Mpox outbreaks in countries where it remains endemic. I asked her how she felt back in 2023 when the WHO declared the public health emergency for Mpox over.
I was stunned. I said, we are still having transmission. It's not quite wrapped up. It might have been rapidly brought under control in Europe and North America, which for the 2022 outbreak, the Americas and Europe, right, they had the highest numbers. They had brought it down under significant control. But the African countries that had been plodding along since 1970 were still getting spikes. And actually, DRC started to have the rumblings of another spike just as the global pandemic was being declared over. So once again, it seemed as if what was going on in African countries was not grandfathered into that decision to declare the pandemic over.
When an outbreak is declared a public health emergency of international concern, it triggers a cascade of funding and activity.
So once they're declared over, those things are pulled back. And so we in African countries, we lost ground because this pandemic was declared over in 2023. And we are seeing the effects of that declaration right now because we have outbreaks really out of control.
You could, for example, have used that momentum to get these vaccines approved in children.
In children and for African countries. We could have done that, but we didn't get grandfathered into that decision. And before it became a global outbreak, it was, a neglected tropical disease that African countries had to deal with. Not really much of a problem for the rest of the world. And then it became a global outbreak. Then we paid attention to it, but only for high-income countries outside Africa. They dealt with it. It seemed to be going down. So, hey, we've declared the pandemic over. That is not right. And unfortunately, the way I'm seeing things going is the advocacy for vaccines and therapeutics and attention for African countries is being justified as if we don't do something, it'll spread worldwide again. Not for the fact that if we don't do something, African people will be affected and die. And that is so wrong, and that is not what global health is about. But unfortunately, we talk about the definition of global health over and over again, as in health for all, health without borders. But we are repeatedly seeing that the action is not along the lines of health for all or health without borders. And some of this stems from racism, I just have to say that. And from looking at African people as really not worthy of investments in their own health. Now, there are critiques reserved for African leaders, that's leaders of heads of state that should be doing better. But in that vacuum, there are people still being affected. And we need to be able to address this with the support of the rest of the world.
It's very powerful what you say. I wonder, to end, what needs to be done differently to put that global back into global health, particularly to protect children?
First of all, and it seems like a pipe dream right now, that we should actually have global solidarity. We should actually have, for countries that either are priced out of buying vaccines, because that happens, or countries that simply do not have access, do not have local manufacturing, that we must have donations that are enough to do something. If we need 10 million doses of Mpox vaccine, we cannot be handling 200,000, 300,000. It's just not enough. We need enough to actually have an impact. So that's one for globally. But then for children, we cannot keep making products for pandemic response that children are not eligible for. Diseases are not going to consider the age of the patient. If they are going to affect the most immune compromised, they're going to pick them. And those are going to be children and people with immune deficiencies and or on treatments that cause immune deficiency. So children have to be addressed. And there are people who are well equipped, have the skills to do research in children and to work with these companies to manufacture these vaccines that are appropriate for children. So we must stop putting children second or third or fourth or whatnot in the line of pandemic response products. Children have to be at the forefront of decision making.
That's it for this week's episode. We'll put a link in the show notes to the original stories that Wolfgang Preiser and Nadia Samagudu published on The Conversation, and to other stories across our global network on the ongoing Mpox outbreaks. This episode was written and produced by Mend Marawani and me, Gemma Ware. Sound design was by Michelle Macklem, and our theme music is by Nita Saul. Stephen Kahn is our global executive editor. You can connect with us on Instagram at theconversation.com or email us directly at podcast@theconversation.com. You can sign up for The Conversation's free daily newsletter by clicking on the link in our show notes. And if you like what we do, please support our podcast and The Conversations project more broadly by going to donate.theconversation.com. Please do also rate and review the show wherever you listen. It really helps us reach a wider audience. Thank you very much for listening.